Hi, good afternoon, everyone. Thanks again for joining us for this virtual town hall on congenital syphilis. My name is Lubia. I am the manager for community public health outreach at the Illinois Department of Public Health at IDPH. And I'm also part of the Office of Communications within the agency. And so my role is to bring information about what the agency is up to and what our priorities are out to communities. However, if it's a virtual setting or in person, trying to get the word out as about different topics that come up through our agency as wide as possible. So thanks again for being here, for registering for this event. We're really excited as an office and as an agency to have Dr. Maura Quinlan with us as our women's health medical advisor. She's going to be speaking about congenital syphilis, and she has a presentation. And then afterwards, because this is a town hall event, what we'll do is we'll have a time to ask questions. There'll be a space for everybody to put their questions in the chat. We'll have an opportunity to have maybe questions if you can come off mute and ask your question in person, but just that opportunity to engage with our medical advisor for women's health, and then get that personal question or something that you had on your mind about congenital syphilis, get asked or have it presented to Dr. Quinlan. So anyway, without further ado, I just one other thing that I wanted to touch base on is housekeeping. So as you'll notice, as you entered, you were on, everybody comes in on mute, and that stays locked until our question and answer session. If you do have a question and you wanted to ask it right away, please feel free to use the chat function so that you can have your question stored there. And throughout the session, I will monitor the chat and make sure that your question gets asked at the end. Other than that, I will turn it over to you, Maura. Thanks again for being here and for having this conversation with folks that registered. I appreciate it.
Of course, my pleasure. Let me share my screen and go to the beginning. Okay, Libya, that's good. You can see, okay?
Yep, I can see it.
Okay. So thanks everyone for joining. As Louis mentioned, I'm Maura Quinlan. I have been practicing OBGYN in the States since '92 and have been in clinical practice for decades, obviously, and have been for the last year in my role as women's health medical advisor. And one of the things we worked being worked on prior to my coming, and I was able to join the team, was about congenital syphilis. So what I want to talk about today is what is it, why is it a crisis in our state and others, and what can be done to help. I'm gearing this sort of for a non-medical group, so hopefully it's understandable. So let's get going. So what is congenital syphilis? Syphilis is a sexually transmitted infection. Congenital syphilis is a preventable and treatable infection of the fetus during pregnancy. The infection is transmitted through sexual contact to the pregnant person and then across the placenta to the fetus. So adequate treatment for syphilis, which is we'll talk about, is a penicillin antibiotic, not rocket science medication. Adequate treatment is 98% effective in reducing or eliminating congenital syphilis. So specifically, congenital syphilis is not if a pregnant person was treated successfully during pregnancy, it's when the treatment didn't happen or the infection wasn't known, and then the baby is born infected. So why are we treating this? We're treating this to avoid these complications that happen if syphilis is untreated in pregnancy. So if the pregnant person is not treated, she has and this is all stages of syphilis that we'll talk about in a minute, she has a 21% increased risk of stillbirth, the baby dying before birth, before delivery, a 9% increased risk of the baby dying at some point after birth. There is an increase in pregnancy complications like miscarriage, prematurity, the baby not growing well, and being born small. And then for infants who survive all of this and are born with untreated syphilis, there's a lifetime of health problems for the infant. Developmental delay, hearing loss, there's some characteristic teeth and bone abnormalities. So a lot of complications if this is untreated. So the risk factors are kind of what you would imagine if there's a high rate of syphilis in a community. When someone is sexually active within that community, they're higher chance of getting it. The more partners, the higher chance of getting any sexually transmitted infection. Having other sexually transmitted infections, including HIV, increases someone's risk. Recent immigration increases someone's risk. We're seeing that with the new arrivals into Chicago. Incarceration increases the risk. Transactional or survival sex increases the risk of syphilis. Unstable housing, and hugely related is limited access to prenatal care. So if someone's not tested in pregnancy, then their baby can be affected. Important to know, though, this data is from a article published in the specialty journal for OBGYN. But when they looked at national data over 4 years, they found that almost half of the cases were in pregnancies that had none of the risk factors for mentioned above. So you just can't tell, which is why we test everyone, that we'll talk about in a minute. So let's talk about demographics. Black women had a higher, this is from the 2022 data, had a higher 4.5 times higher chance of delivering a child with congenital syphilis than their white counterparts. Hispanic women, 1.8 times higher. If someone's low income, their rate of congenital syphilis is higher. It's more common in rural communities. And then the immigrant population also has a higher risk. So it's important, this is getting a little medical, but it relates a little bit, it helps the understanding. Unlike something like chlamydia, gonorrhea, you have it, you don't, you're treated and it's done. Syphilis there's a variety of stages, and many of them, really most of them, have no symptoms. So for example, primary syphilis is a sore, usually a painless sore on the penis, vulva, or mouth, all over, could be where in any place. Secondary syphilis generally involves a rash, but those can be subtle. So someone can have no history of any of those symptoms and then be early latent, which means it's been less than a year since they first got syphilis. And then late latent stage is someone who has had it for at least a year or longer. And so this is part of the complicating factor of diagnosing and treating syphilis. Late stages, tertiary syphilis, neurosyphilis that can have brain involvement, syphilis affecting the eye, vision and hearing can happen at any point, at any stage. So transmission to the baby depends a lot on the stage of the mother. So if the pregnant person has primary syphilis or secondary or early latent, meaning she's had it for less than a year, that's the highest risk, up to 80% risk of transmission from the pregnant person to the fetus. If she has late latent, meaning hard to tell when she first had it, but our best judgment is that it's been at least a year since she first got it, that's a 10% risk of fetal infection. It's thought that the greater transmission happens as the pregnancy progresses because the placenta is bigger and more of the syphilis spirochete can pass. So let's look at numbers. This is where we get into why we are having this conversation. So this graph is Illinois data. The blue bars are the rates of primary or secondary syphilis in women of childbearing age. So women, and that's often thought of as a marker for risks of congenital syphilis. So women age 15 to 44, this is the primary and secondary syphilis rate from 1994 through 2022. So when I trained in the 90s, it was quite common, and it was lower. And you can see in like 2007, the risk, the thought was, and when you look at papers from that time, it's tragic because some of the authors say it's almost done, we're done, it's eradicated. Not so fast. So you can look and see it's a U-shaped curve. It's going up in the recent years. The dark orangish line is the congenital syphilis number. So of course, if women of reproductive age are more likely to get syphilis, some of those will be pregnant, and then the babies will be affected. So this is the specifically congenital syphilis rates comparing Illinois to the US. I don't know if we should be happy or not, but our rates were higher than the national average in like 2020. Now it's a tiny bit lower. I don't think any of that's anything to be proud of, but just know that we're about 20th or so in when you compare all state rates of congenital syphilis. So we're sort of in the middle, but we are not the only state. Certainly other states are having this issue. So let's just look at those are rates. Whoops, sorry. Those are rates. This is just the numbers. So in 2017, there were 22 infants born with syphilis in Illinois. You can see in 2020, it was 29 and went from 29 to 50 to 84. About half, roughly, of the cases every year are in Chicago. The other half are about 10, some are in the collar counties, and the rest are in downstate. So it's certainly evenly spread. But this is just where we feel like that we have to do something. So what is the law? We're starting on what's been done to help decrease these numbers. So for those of us who provide prenatal care, the law in Illinois says that every single pregnant woman, so again, you can't tell by their history for all cases, every single pregnant person needs to be tested for syphilis at the very first prenatal visit, which we have really always done. But since the mid 2000s, a law was added requiring every single pregnant woman to be tested again in the third trimester for both syphilis and HIV to catch those women who may have contracted syphilis after the first prenatal visit. We recommend, the law recommends ideally testing in the early third trimester, like 28 weeks or so, with a few months left to go in the pregnancy, so that the successful treatment for the infant needs to happen the treatment needs to start a month before delivery. However, this law looks great. However, there's documented disparities, and this reference here is a group at Northwestern who looked and to see who was following the law. And there's a decent number of providers who are either unaware or just seeing patients and not following that additional third trimester testing. So this is what it looks like for those of us in practice. This is the prevention cascade. What do we do to try to decrease the numbers of congenital syphilis? The first step is at the very first prenatal visit, we test everybody. If they're positive, we treat them. We test and treat their partner. If they're negative, we treat them again in the third trimester. If they're positive, again, treat them, treat their partner. If they're negative, the recommendation is to test again at delivery in areas that have a high prevalence in the community. The American College of OBGYN, which is my professional group, came out just last week with a recommendation that every single person in the country, every pregnant person, should be tested again at delivery. So that may be changing, that we test everybody 3 times. So not to get too deep in the weeds, but just to talk about how hard this is. The treatment of syphilis depends on the stage. Early syphilis, if someone's had it less than a year, the treatment is 1 single shot of penicillin. It can't be oral, it has to be an injection. That's the way it gets to across the placenta. Oral doesn't work. If someone is greater than 12 months, so if they're that stage, they need a shot given at 3 doses a week apart. The interval can be anywhere between 5 and 9 days, but if someone gets a shot 10 days after the last one, they have to start over. It's related to how fast these spirochetes replicate. If you've waited too long, you have to start over. So that life can get in the way for patients who need this treatment because they need 3 shots between 5 and 9 days apart from each other. So to add more challenge to this, bicillin, so that's the trade name of this penicillin shot, there's a shortage. Literally a tornado hit one of the Pfizer plants that make this a few years ago. We felt like it was just what next, but there is a shortage of this kind of penicillin. And so this slide is from the CDC page of how to treat sexually transmitted infections. And they specifically mention the shortage and that the bicillin should be saved for pregnant women and infants because there's no other treatment for them. if someone's allergic, there's a way to help desensitize. But unfortunately, we're in Illinois, we seem to be pretty good. There's no, to our knowledge, there hasn't been any pregnant person who wasn't treated because there wasn't bicillin. It's just getting a little bit complicated. For men, for pregnant people, if they have that latent stage, the treatment is an antibiotics every day for a month, doxycycline. And so for many folks, that can be tricky to remember to take the pill, which is why the shot is used often. But again, as of now, with the shortage, it needs to, the shot needs to be saved for pregnant women and infants. So the concept of congenital syphilis numbers going up has hit the national news. And last November, the CDC has this document called the MMWR, the Morbidity and Mortality Weekly Report, that is a document that they sort of put out weekly to show new issues, cutting, what's new in the world, particularly of infectious disease. And they talked about congenital syphilis, and they were really, really strongly wording that it was that congenital syphilis there's missed opportunities. This is more from that MMWR, and they described that syphilis in babies is a health system failure. They did not mince words, that the system failed these infants and their moms. The middle number, that 9 in 10 of cases of congenital syphilis would have been prevented if the pregnant person had timely testing and treatment. The CDC has made these categories of where is the missed opportunity for every single case of congenital syphilis. What happened? Because we know how to diagnose and treat this. In the Midwest, you can see that I put a little red box at the bottom. 40% of the cases in the Midwest in 2022 were related to no testing for syphilis in pregnancy or the testing not done in time. So many of those folks are people who didn't have any prenatal care and came to the hospital in labor. And then, of course, you couldn't treat them in time. But 30% of them, 31% in the Midwest, were those who were adequately tested. They were tested in time, but not treated or not treated adequately. So that's a place that we can really help. So after that, a few weeks after this, the nationwide data, the MMWR had information about Chicago by some of my colleagues in Chicago of what the numbers were like here. And this is just a kind of a busier slide to show the missed opportunities. Where did we go wrong, or where could we help prevent this in the future, depending on where in the state. So in Chicago, again, these numbers aren't huge, but in Chicago in 2022, 60% of the cases were when patients who were not treated during pregnancy, even though they were tested in time. Couldn't get to the clinic once a week, mistakes or not being staged appropriately, a variety of reasons. If you look at Cook County, there were just 10 cases in suburban Cook County, excluding Chicago. And for those, half of those cases were in that category, diagnosed in time, but not treated adequately. In downstate, it was a bit of a split, but a few more cases were, the majority, 45%, the largest category was no timely prenatal care. So this got a ton of press around our state, around the country, about this missed opportunities. So in defense of my colleagues, I have been in this position. It can be really hard when you have a pregnant patient, her syphilis tests are positive. It's not a one test, there's 2 tests, one is more specific than the other. To interpret those tests, was she treated before? Is this test positive, but she's adequately treated? And this is from an article for OBGYNs, and I highlight that diagnostic quandaries are common and lead to patient and physician distress. So this challenge of how to make the diagnosis and the correct treatment is being addressed by IDPH, and I'm really proud of this concept. So the perinatal syphilis warm line was launched November 1st. It is an expansion of the perinatal syphilis hotline that all of us in practice have known and respected for decades. A warm line, just for those who wonder, the difference between a warm line and a hotline is that warm line calls are answered within a day and not necessarily immediately. So this is from the press release. There we go. This is from the press release in November. Describing what is this warm line. It's for providers to call with questions. The providers can call and get clinical guidance. Many people haven't seen much syphilis in their career, so to call and say, can you help me? I've got this patient. Here's what her numbers are. Here's her history. Here's what I'm finding on exam. So there's adult and pediatric infectious disease doctors and maternal fetal medicine doctors who will provide clinical guidance. And really importantly, so it's for pregnant women and newborns, but really importantly, I am embarrassed to say I didn't know, and I don't know any colleagues who knew, that the state has all the syphilis results that have been done in the state, because it's a reportable disease. So the labs report all their syphilis testing. So if I have Jane Doe in the office and she thinks maybe she was treated in Springfield, the warm line will help me find out what her numbers were, her syphilis testing numbers, and when she was treated. Hugely important to make the correct diagnosis. So the warm line will help link to that past testing and treatment, and help providers report and link to resources in their health departments. And this is again for pregnancy and for newborns. And a lot of the calls they've been mixed, but there's certainly been a good number of calls from the newborn nursery with a newborn syphilis test positive, the mom positive, and some just needing clinical guidance for what to do, how best to treat them. So let's talk about, oh, here, the phone number. Yes, sorry. Someone asked, I'm glad it came up. Yeah, this is the number for the warm line. And again, it's for providers, but it's hugely helpful because it's really making this diagnosis can be really complicated. So what else are we doing? So that's sort of provider help. But we need to have help. People in the community need to know that it's important to get tested. So I went to a conference just the other day and love these graphics. This is from the Northwest Portland Indian Health Board. So culturally sensitive and appropriate and just beautiful graphics. You know, pregnancy and parenthood are sacred times. Get tested for syphilis. Cases are on the rise. Get tested. It's hard to spot. So this is from just an example from another state's community effort to educate the community about this. This is in Chicago, but get tested. The bottom is a billboard that is somewhere off a highway somewhere in Chicago about getting tested. Outside of Chicago, here we are today doing the down hall. One of my colleagues is doing it in Spanish early next month. The bottom picture is Dr. Anna Young, who spoke at Aurora in a press radio show, both in English and Spanish. So, and there's some print material getting worked on by the communications group at IDPH. So what else? There's obviously so much. I feel strongly, and having been in practice, know that one of the barriers, it's really hard if someone doesn't come for care, but if we get the word out that this is there, if we get the word out to other providers, you know, we talk about the law saying that you have to test pregnant women at their first prenatal visit. We sort of think of that as like an OB, a family practice, a midwife in the office, but there's discussion of like all care for a pregnant woman is prenatal care. So if a pregnant woman comes with a twisted ankle and hasn't had care yet, it would be so great if the ER, urgent care, other providers would do syphilis testing. So trying to get the word out. But this sizable number of pregnant people who were diagnosed, maybe the treatment started, but they didn't get what many of them need is the 3 doses. Other states are having a mobile van. So the first dose given in the clinic, make sure they're not allergic, all that. And then could we try to bring the penicillin shots to them? Other states have been doing, just started doing this. So there's discussion of doing this for Chicago, having a single mobile unit, a nurse with a car, who providers can reach out and say, you know, this woman's struggling with childcare, work. Can you go to her? Here's the date. Here's the few days that when she needs her treatment. Clearly downstate, that's not ideal because it's such a big state, for someone to go to, you know, north to south, for these cases. And there would probably be about sort of 20-ish people in Chicago who would benefit in a year, maybe the same number downstate. So we're discussing with some of the IDPH divisions to see if there's a way to do some intensive case management. Perhaps all the positive syphilis tests in pregnancy will be coordinated by a single site or a single group that will then do case management and reach out to folks to make sure they're getting the treatment they need and help them with creative car vouchers, you know, other places that are open, excuse me, other hours, et cetera, just to help make sure people are getting treated. The most cutting edge is point of care testing and treatment. So as I mentioned, when we test someone for syphilis, it's 2 tests. There's one and then another to confirm. So it's not like HIV where you can do it, you know immediately. But there is some thought that one of the tests being positive to capture people and start the treatment, you could do a rapid test and start treatment while you're waiting for the second test to come back. So there's thought. Indiana just did a pilot at a WIC office, doing point of care testing and treating at a WIC office. So there's lots of ways that at IDPH, at Chicago CDPH, Chicago Department of Public Health, we're talking about those other creative ways to help this issue. So in summary, syphilis is rising nationwide. It's rising among men who have sex with men. It's rising in women, and rising then follows that it's rising also for infants. We know it's easy to treat. The treatment is a penicillin shot, and it's just a matter of finding out the breaks in our system, the missed opportunities, as the CDC describes, and help decrease this rise from there. And things like this town hall to get it out there that this is not something that is in the past. This is here, and testing and treatment can prevent it and all the complications in the baby. So that is my bit. I hope I wasn't too fast. I want to thank all of you for what you do for your communities, and I'm here for questions in the future, and happy to talk to anybody anytime about this. I will stop sharing my screen.
Sure. Thanks so much, Maura. Really appreciate all of that information. I did, so when folks were registering, we had an option for people to submit questions, and we did get a few, but I wanted to start by inviting people to unmute themselves, and to do that, just raise your hand. If you could virtually raise your hand and press that option, I'll see it on the attendees list, and then I can unmute you. But the first question that we had that came through was around the numbers, right? So I think in the promotion of this virtual town hall, I included some figures, and I think there was something around, there was a 300% increase that was being talked about. I saw there was another statistic that I saw was a 561% increase. So there's all these kinds of statistics thrown out there. And so I wanted to ask you, Maura, if you could talk a little bit about where these data points are coming from, and then if there's an agreement as to what the numbers really are.
Yeah, so that's a great question, and it depends a lot on how it's defined. So is it the number of congenital syphilis cases? What percent increase? If you'd say from 2 years, like if I look at the slide, if it goes from 50 to 80, that's a different increase than the year before was 20 to 50. So, or 20 to 25. So that percent, and I agree with you. I've seen it, like some seem really small, and I was, they're comparing 1 year to 1 year. So it depends on the years, how many years apart that you're talking about is generally the explanation. All of them are going up sort of in the same way. syphilis for men who have sex with men, syphilis in infants, it's all a rise. So that number tends to be, how many years apart are you talking? It's bad. It's a lot. But
Sure.
but you're right, that can be confusing. How high is it? But again, it depends on which 2 years you're comparing.
Sure, sure. Thank you so much for clarifying that. I wanted to ask again, if anyone wants to come off mute, just hit that raise your hand option, and then I'll see you and I can bring you off mute.
There's the question in the chat.
Oh yeah.
Um,
my attendees list is blocking.
Yeah, no, that's okay. I blew up the chat so I could see it. Treatments from George. Treatments are going to be available for free at the health departments. If so, how can we get penicillin for our health departments? Excellent question. And because this is reportable, there's a whole lovely world of great people who are on the congenital syphilis team within the STI division at IDPH, and they know where it is. They know the penicillin, who's got how many boxes of penicillin. And there's parts of the state that have a lot and parts of the state that say, like, we are down to our last box. So there are state IDPH central people who will help make sure that there is no person who's told, shoot, we can't help you, we don't have any penicillin. That is not happening, because at the state level, they will make sure it's at each health department. And some health departments have like brick and mortar clinics that have STI clinics. Some don't. It's a little bit all over the map, which is a bummer, because when we did a survey last fall, we asked the people who answered the survey, there were about 70, a lot from health departments. We asked them, do you treat STIs? Yes or no? If yes, do you treat in pregnancy? Yes or no? If yes, do you treat syphilis in pregnancy? And there were quite a few who don't treat infections if the person's pregnant, which as an OB, I feel like you treat 2 people if you do that. But I get it. People are afraid of pregnant people, but and the risks, even though the risks of treating are 0 and the risks of not treating are huge. But so some health departments, a decent amount of them will treat in pregnancy. And for providers, for my colleagues at the bedside, if they don't stock Bicillin, that's who to start with, is the local health department. Do you have a clinic there? Can she go there? Where can she go? And that's one of the things that the Warm Line can help providers. Like the Warm Line has all these resources of where to call. All right, let's see. I hope that answered. From Nancy, with the shortage of Bicillin, would you treat a pregnant with positive rapid if she reports a prior infection? So that is such a great question, because it is certainly complicated. And I think the quick answer is yes. So if she reports a prior infection, that's where this gets so complicated. And I am certainly no expert on this, but I have scratched my head with the Warm Line team on some of these hard cases, because you can get syphilis more than once. So if someone says they were treated and their titers, which is the lab number, if their titers are going up, is it new infection? Was she not treated enough? So the concept of rapid syphilis testing and treatment is that you know that you overtreat. So better to treat her there when she's with you, and wait for the test, and the test might confirm that she was past treatment and she didn't need that single dose of Bicillin. But even in the face of a shortage, with what these numbers are doing, the thought is that yes, better to treat while you're waiting for that confirmatory test. We don't do, there's not, to my knowledge, a place in the state that's doing rapid, but the precedent for other states is yes, to treat with the single positive, the rapid test positive, while you wait for the confirmatory. And the penicillin shortage, the Bicillin shortage, is thought to last through like second or third quarter of 2024. So hopefully that will be not long. Oh, Champaign-Urbana does rapids. Oh my gosh, Teresa, I write myself a note. I need to know more about this. I know that the your name down. If you put your email in there, that would be great, and then I can reach out to you. I know that when we did the survey, Champaign-Urbana had so much Bicillin, which is great. They were just ahead of the game. So yeah, I'd be really interested to know more about how that's approached.
Yeah, that's great. I know Nancy put in that they also do rapid syphilis testing. So Nancy, if you could share what organization or which clinic or where you're
Together,
at.
look at
Oh,
Champagne. Wow. And can I ask you while we're chatting if you do for pregnant patients?
I'm happy to take them off mute if you all give me one.
Or if they want to put it in the chat, just because that's huge.
Teresa, I just took you off mute, and then Nancy, I can take you off mute as well. Okay, Nancy and Teresa, if you want to share or chat, you're welcome to do so.
Okay, I actually missed the question. Were you asking if we test or if we treat pregnant women?
If you either, do you do rapids on pregnant people?
So generally we try to we've been doing blood draws on most people that come through our clinic here at the health department, but we do rapid syphilis testing at our outreach sites. So then we do run into some pregnant women at those sites. We do treat pregnant women, but we don't do treatments at the outreach sites because we generally don't have a nurse with us. It's our prevention staff. But we would treat pregnant women, yes.
That's great. Yeah, there's such a, I'm sure you've seen this, there's such variety. When we did the survey last fall, some people said that some of the STI brick and mortar clinics, if the person's pregnant, they send them to the ER for treatment. And I get it in that site. Some, they don't have a standing order from their medical director, whatever, a variety of reasons. But I just felt like, oh boy, that's not the great use of the ER, and the poor woman's going to have to sit there forever because if they triage her, she'll be at the bottom of the acuity. You know, she will wait for so many other people who need more urgent care, and you know, she might have kids with her and just not be able to stay that long. So that's great that that you treat. Let's see. Stephanie asked, "Are you currently doing ongoing seminars to educate patients on congenital syphilis?" Um, You know, the challenge with that is how to do a presentation, and I would leave this to Lubia too. What in what settings can I talk? I'll talk anywhere, anytime, but where can we get the information out there to the people who need to know? This today is one of those ways. I've talked to nursing groups, pediatricians, OBs, all sorts of provider groups. But the English and Spanish town hall is one of the ways. And I think the press, you know, getting like bus benches and billboards and stuff is going to be another way.
Maura, I can speak to
Yes.
that question as well.
Yeah, thanks.
It's definitely a challenge to, here, let me turn my camera on. I don't know what it looks like for folks on that end, but mine is like 2 split screens. So anyway, um, you know, that's you know, educating patients and educating folks in general, right? People across the state. It's a challenge, right? Because we're thinking about cultural competency, making sure that we're doing it in a language that is available to them, and then how to get it into the spaces where, you know, these populations that are affected, where they are, right? And so, like Maura said, we're doing these town halls to try and get the education, the information to groups as far and wide as we can, and then try and field questions. We've also done like awareness campaigns. We've put out short radio messages that just, you know, give a quick bit of information and then encourage people to either look up information or, you know, or engage with our social media to get some information out. Which on our social media, we're also trying to get information out. We've put out some campaigns and some posts to get the message out. I can personally say that I've worked on the Spanish ones, and we're trying to be more conscientious of, you know, the needs and different languages, right? Again, with, you know, trying to identify which communities are being impacted the most, and then kind of working from there. And then you know, working with community-based organizations, faith-based organizations, sororities, fraternities, you know, veterans group, whoever, right? Trying to get those contacts first, and then say, hey, we have this information, like this town hall, like this campaign. Trying, like, can you work with us to get it to more people? And then if we're missing something, if there's a gap, identifying it and then responding to it. So yeah, we're trying, and then this is part of that effort for sure.
Yeah, I see Jeremy in the chat. Love the HIV syphilis test. I feel like the providers who care for the gay LGBTQ community are ahead of the game because they have been doing this rapid testing for HIV, and they have just, like it sounds like at the Puerto Rican Cultural Center, just put syphilis with it, which is great. And for whatever reason, pregnant people just, it's just not happening in the same way. Let's see, Amy says we need to focus on those who treat pregnant people first. 100%. We have tried to educate providers, and again, as I mentioned in that survey that we had about 80 respondents, about half of them are using doxycycline instead of penicillin for non-pregnant people, but half, that means the other half are using their Vicillin. And it's a complicated story because, like you're describing, a man who'd been treated 3 doses 2 different times, and that happens all the time when people are move and it's unclear what their stage is. And I've had providers say, that this patient, it's going to be tricky for them they have trouble remembering, we all have trouble remembering. So to tell someone to take a pill twice a day for a month, as opposed to coming to clinic every Monday for 3 weeks for a shot. So I've had providers say, I just am not sure, like this person has said, I'm not going to remember, or I've started this and not remembered. And I've had patients of my own who are not pregnant, who I see them and say, how'd it go? I know it's hard to take it for the month. And they said, oh yeah, I didn't finish it. I only took a few weeks. So it's sometimes providers, knowing that there's a shortage, just feel like they need to use Vicillin in some cases, just to make sure that the person is treated. Because if they're not, then that person is still infectious, gives it to someone else, and this snowball continues. I look forward to the day that there's not a shortage and providers can treat their patients with whatever they think is best. And infants too, newborns need Vicillin.
Sure, thank you. This comment from Amy Mathis. Obviously, we need to focus on those that treat pregnant.
I just read that one. Sorry.
Oh, I'm sorry.
It's okay.
Great. Any other questions? Any other?
The challenge for us as providers is, for example, in the emergency room, again, if we tested for syphilis for a pregnant person who comes in for another reason, that would be great. And we would pick up many of those, when we've looked at missed opportunities, many of those people, we looked at the downstate data, had what we call touch points. They were seen by a healthcare provider during that pregnancy. It just wasn't prenatal care. It wasn't like an established prenatal clinic site. And I totally sympathize. If you're in the ER and a pregnant woman comes with a broken ankle, you've got so many things to think about caring for that think like, oh, PS syphilis. But a very cool thing that happened at the University of Chicago is that they made, and we have anyone who's in clinical practice, the electronic medical record, they somehow in the Epic electronic medical record system made it that a pregnant person, there would be a pop-up that would say, you're sending labs for this pregnant woman, syphilis is on the rise, do you want to test her? And you just had to click yes. And they really educated the ER providers, like, don't be scared. If it's positive, you don't have to figure it out. They had a champion in the ER who would get all the positives, like, just test. Someone, Judy is going to call them and she will take it from there. And they diagnosed a number of pregnant people with syphilis that would not have been diagnosed otherwise. So you hate to have to do that kind of thing, but I know how that is, that I've been in clinic and the patient's got a million issues and we're going through them, and it can be easy to forget things that are not the immediate need for the person. And if it pops up, it goes, oh, that's right, syphilis. So we have other ways that we can make that happen.
That's really encouraging to hear and to know about. The hope is that there's so much going on, but that these reminders could be really helpful, and hopefully it could be something that other clinics and other spaces could replicate. I did have a question, and this one came up as we were planning for these town halls, especially around the populations that are being affected the most, right? And the research that we're doing, and that the numbers and data that are coming through, And one of the things that I mentioned when we were promoting these events is that Black and brown women are being affected the most when it comes to congenital syphilis in pregnancies. And so I wondered if you could speak a little bit about that. I know that you've kind of brushed on it throughout your remarks, but I wondered if you could speak a little more and spend a little more time there.
Yeah, of why that is. It's a great question. It's definitely true. And I think it's a variety of reasons. One of the reasons might be access to care. Does the pregnant person have easy access to a provider who will take their insurance, who has convenient office hours, is convenient to get through, to get to? So some of it is that. Some of it is, so that is our barriers that might more affect a Black and brown pregnant person. The other thing is access to treatment. So if someone's got, caring for a aging parent and got kids at home, and you tell them to come every week for 3, that can be hard in a work day. So a lot of it is access to care. And I think that the hope for especially doing this education in English and Spanish, that we can get the word out so that pregnant women know this is still here, syphilis is still here, get tested, and that we can have that warm line for doctors to be able to reach out and find out the best way to treat that person and link them to resources to make that happen. So I think a lot of it is access to care.
Good to hear. Does anybody else have any other questions, comments? Again, you can put your question or comment in the chat. You can raise your hand, quote unquote, and I can unmute you, unlock that option for you. But then, as we're waiting for some more comments to come through, I did have a final question. So, the spirit of these town halls and to get this information out is to do a call to action, right? So we want, not only are we trying to empower or inform the community, but also to empower them. And so I wondered if you could talk a little bit about what we in this town hall can do, what they can communicate with their communities, like how can we get this information further out, and then what action steps can we communicate to empower pregnant women and people to get tested?
Yeah, that's great. I think what we can do is get the word out that this is here, that congenital syphilis is rising. Get tested. It's rising. It can be catastrophic for you and your baby. Get tested and get treated. And I think my sort of aside for providers is to promote the warm line. Like, there is resources, because it can be really hard to know what stage that person, and some of the mistreatment is incorrect staging, and someone treated with 1 dose of penicillin, they needed 3, and their baby was born sick. So kind of just getting the word out is, I think, the most important thing for us to do now.
Wonderful. Thank you so much. Again, final call for questions, comments for Dr. Quinlan. And as we're waiting, I just want to say thanks again for making time for this virtual town hall, and then for connecting us with Dr. Espinal for the Spanish town hall. And just so folks are familiar, as Dr. Quinlan mentioned, we're doing 2 virtual town halls. This is the first, right? And this was English only. The next one is going to be on Friday, May 10th at 1 p.m. and that will be Spanish only, right? So it'll be similar information. Dr. Mariana Espinal from Northwestern Memorial will be facilitating that conversation, sharing out very much similar information, but in Spanish only. And so if you know anybody who might be interested, if you feel like that your community needs this information, the information will be sent out via email to everyone who registered for this event. And then will also be available, the information will be available on our social media platforms, specifically on LinkedIn. If you have a LinkedIn, we were able to create a great event page that you just click. I think you make 2 clicks and you're registered or something like that. It made it easier for folks to participate and to join us for that event. So Also, just a quick note that this conversation is being recorded and will be shared out, not just with the registrants here, but also on our social media platforms. We'll make sure that this information is accessible throughout. And then, hopefully, although I hope not, but, if this information is needed in the future, we can definitely revisit this conversation and bring some other voices in as well. So again, thanks, Dr. Quinlan. I really, really
And if
appreciate
I can I just add a little tiny bit? If we can help anyone in their community, I'm here. Dr. Espinal, who's a native Spanish speaker from Venezuela, she can talk. Dr. Mary Tate is a great friend and colleague. She's African-American, works at Stroger. So if there's any, if not that it matters the color of the person speaking, but if you need help with your community in any way, please reach out. I'm happy to do it.
Absolutely. Yeah. Both Dr. Quinlan and I are, not only passionate about this, but also passionate about getting the information out and helping you all get that information to where you need to. And, we're trying to cover a big space, but if you want us to focus on your area, or, that a population is really going through it, let us know. And we're definitely available and willing to assist.